How many of you know what the Institute of Medicine is? Only a few of you. So you've probably all heard of the National Academy of Sciences. There is a companion organization under that whole National Research Council umbrella called the Institute of Medicine. And they are often called upon to bring together groups of experts across the country to advise different government organizations. And in this case, I was asked to be on a committee to look at the safety of medical devices. Now, medical devices are not my area of expertise, but software and security are. So I was the only software person in this group. And so what I'd like to talk with you about today is why we were convened, what our task was, what some of the software issues were related to the medical device problems we were looking at, what our general committee findings were, and what's particular to software. I think this is an instructive example for a lot of reasons. One is that all of us who grew up in the software arena sometimes forget about the effect of our products on people who actually have to use them. And there are all kinds of policy issues about how to view software in the larger context of the products and processes that we use in our daily lives. So let me start with the Institute of Medicine's task. This committee was put together at the request of the Food and Drug Administration. So the funding for all of the committee's work was from the Food and Drug Administration. And I will show you a little bit about the way in which medical devices are approved in this country. It's not like drug device. It's not like drug approval. Ordinarily, when you approve a drug, you can do all kinds of upfront testing. You can use large numbers of groups, some as the control, some with the treatment, namely using the drug in various contexts. And you can do some statistical analysis about the efficacy of the drugs. Device approval is very different for a variety of reasons, not the least of which is that for many of these devices, there are very few people who use the devices. Some of them are very specialized. And so it's very hard to get large numbers of people in a trial to look at statistically. So you have to have other ways of coming up with a rationale for saying, yes, it's okay, or no, it's not, to allow a device to be used by the general public. And as you'll see, I'll describe something called the 510K process, which was a way that was come up with in 1976 to speed up the approval process for certain classes of devices. So the task of that was given to my committee was, does the current 510K process optimally protect patients and promote innovation in support of public health? Okay, so we had this process that's been around since 1976. There are pros and cons to the process, which I'll describe. So are there ways to fix things in this process? And if the answer is it's not doing its job, what legislative, regulatory, or administrative changes are recommended so that the goal of the 510K process can be met? So most of the people on my committee were lawyers, ex-regulators, healthcare professionals, a variety of people, but nobody else looking at software. Now, what does the 510K process intend? Well, normally, for a new device, it takes a long time to get approval. And the FDA uses two terms for what you and I would call approval. One is approval with the regular long-term process. The other, going through 510K, is called a clearance process. That is, the FDA doesn't approve the use of the device. It clears it for use based on evidence that, according to the 510K process, it's substantially equivalent to a device that's been approved. So that's the idea of the fast tracking that you can get through 510K. The idea is, if you're making small changes, small enough to be considered substantially equivalent to something that's gone through the longer process, then you can show the evidence of substantial equivalence, and that makes it the same, and so they fast-track the process. Now, for some things, that seems to make sense. For instance, if I make a device that's made out of a particular kind of plastic, and I want to change the plastic to another kind of plastic, but the device is otherwise exactly the same, if I can show that the characteristics of the two plastics are substantially equivalent, then I can apply the 510K process. So that should relieve the burden from the manufacturer of having to go through the longer process. And of course, people need some of these devices, so it also speeds up the availability of the process. So it speeds up the clearance process for devices that are substantially equivalent. Those are called predicates, the thing on which you are showing you're substantially equivalent. And it's not intended for classes of devices that can most seriously threaten health. So things that are big deal risks to health still have to go through the longer approval process. And there are other pathways involved. And as I said, this is based on 1976 legislation. So how many of you know when the Food and Drug Administration was created? 1930s. Okay, so about 40 years went by before they changed this process. So I found this on the web. There are lots of pictures like this. It's hard for you to read, but it's an example of a comparison between the pathways to market through the regular approval process and the 510K process. And the thing to pay attention to is concept and design take about the same amount of time, about 12 months. You've got the engineering part that takes 2 to 3 years. But then here, it's very hard to read, but the 510K process takes between 0 to 9 months, and the regular approval process takes from 9 to 36 months. So that's a huge difference. Okay, and if you want to get something out quickly, then the 510K review process from the FDA takes 3 to 5 months for 510K, and for the regular approval process can take between 1 and 2 years. So this shows the biggest differences between the fast tracking of the 510K and the longer term of the clearance process. So one of the big issues is, what's the role of software? In the 1930s, they didn't have to worry about software in medical devices. We didn't have software in medical devices. In '76, we were starting to have some software in medical devices, but still, when people thought about medical devices, they thought about them as instruments. But in fact, software can be used in 3 big ways. They can be used in the devices, as a device, like electronic health records, and to produce devices. So you might, for instance, write software that runs the machinery that creates the hardware that's the device. Whereas in a hearing aid, you have software in the devices. So for example, my husband has hearing aids, and his hearing aids have software in them that he gets tuned up periodically as his hearing changes. But it also can sense when he's on the phone, and when he's on the phone with one ear, the 2 hearing aids with software communicate to each other to tamp down the sound in the other ear so that he can hear better on the phone. So there are good reasons to have software in medical devices. The software can, in many cases, improve the way the device works. Now, there are lots of issues related to software in medical devices, especially since 1976. There's increasing use of software in medical devices. And I'm going to talk about all of these in more detail. Software is very different from hardware, and I'm going to go over what that means in terms of the clearance process. We need some sort of systems approach so that we understand how software fits in with the hardware that it's running. And we need to look at what we can learn in advance from the predicate. We also need to look at what we can learn from development and testing and what we can learn post-market. Post-market means once the device is out there for people to use, then there are reports back to the FDA if something goes wrong. And you've all read about those in the newspaper. So let me start with the increasing use of software in medical devices. The FDA puts out all kinds of guidance for software in medical devices, and you can go online to the FDA site and look at all the guidance. It's quite interesting to see what kind of guidance they give. But they did an analysis a few years ago of the software in medical devices. They looked at a little over 3,000 medical devices that were medical device recalls. Okay? So I talked about post-market feedback. If a manufacturer reports to the FDA that there's a problem, and the FDA determines that the problem is serious enough to recall the devices, then there are all kinds of data that have to be provided and made public. And so the FDA could go back and analyze the device recall data. These were recalls between 1992 and 1998. So almost 8% of them were attributable to software failures. Okay? And of those software-related recalls, 79% were caused by defects that were introduced when changes were made to the software after its initial production and distribution. Okay, so yes?
Of those 3,000 devices, did all of them have software? Or is it some subset that had software?
I think these are ones that had software. Now, when we had our committee meetings, the way the committees work is that you often hold public meetings and you have people come and provide evidence to the committee and to the public who are attending the meeting. And so for one of our meetings, we asked Kevin Fu at the University of Massachusetts, who studies the safety of medical devices, to analyze what the growth is of software over time in medical devices. And from his presentation, which is also online, you'll see that 24% of recalled devices rely on software. Now, you had a question?
What was the biggest category of faults? Like not the software, not...
Yeah, but you mean within software?
No, not within software, in general.
Oh, in general. I don't really know. You can look online and check, but I don't know. Yes?
Do you have any idea how many actual end-user devices these recalls accounted for? Like not types of devices. Like that's really what you have there.
Yeah, that's types of devices. You're right. I may have that on a slide later on. But I know I have something that will at least give you a sense. For some of these devices, you might have 5 people using the device, and and for others, you have thousands.
Just out of curiosity, is the 510 or 501 process?
The 510K process, yeah.
In it, does it account? Like, is there more scrutiny on a device that will be used by 1 million people than a device that's been used by 2 people?
So there are different classes of devices and different categories within those classes. But the class basically relates to severity, and that's taken into account when they decide what class a device is in. So the ones that are of the highest severity, they might have the highest impact on people. Those are the ones that can't go through 510K. Okay. So from Kevin Fu's analysis, 11 through 9, so this is a more recent period. The one I showed you on the previous slide was 92 to 98. This is 99 to 2005, 11.3% of the recalls were attributed to software. So that's up from 8%. And 49% of recalled devices relied on software. And there was an articulation point in 2006. After 2006, over half of the medical devices that are on the market today rely on software in some way. So that's a huge change. So there's a lot of software in our medical devices now. Now, this goes to your question. Between 2002 and 2010, there were 537 recalls of software-based devices, and they affected about 1.5 million devices. Okay? Now, some of them are devices that are external. They're devices like this. Some of them are internal, implantable devices. Now, I don't have data on the difference, but still the magnitude of this is pretty big considering the population that uses devices in general. Yes?
Just so I want to make sure I'm understanding the data correctly. The first bullet point, we should actually Because even though the percentage of recalls attributed to software has gone up, the number of devices using software has gone up substantially. So, as a relative pool, software is going down.
Yeah, you know, like a lot of these things, the answer is fuzzy. It's not clear, for example, whether the numbers are going up because there's more software in devices, or whether people are more aware of certain kinds of problems and they report them more often. It's not always clear. And it's not clear, I haven't shown you anything yet about the severity of the failures. If it's because the screen is changing from blue to green and it shouldn't, that doesn't matter. If it's because the battery is prematurely wearing out in your implanted pacemaker because of some software drain on it. In fact, that's a kind of attack. Kevin Fu, in some of his security work, has shown there are ways, if you want to kill somebody who's got or hurt somebody who's got an implantable device, you can do things to keep the battery always at its highest level instead of letting the device be asleep when it's not needed. So it's not always clear when you look at these gross numbers what the impact is on individuals. And it's not clear when it's the fault just of the software or of the interactions of the software with other parts of the device. Okay? Now, the FDA has given guidance that says the use of off-the-shelf software in automated medical devices and in manufacturing and quality systems operations is increasing. So the FDA has recognized all of this, and they've updated their guidance periodically. However, what we don't want in these devices is what I'll call fragility. We don't want them to be unreliable and unavailable. We don't want them to be insecure, and we don't want them to have unpredictable behavior. So here's an example from software in a device. Now, imagine this as a kind of tape from different incidents from a device. You read it from the bottom up. So things are going on in May of 2007 at 2:59, at 3 o'clock, again at 3 o'clock, and so on. And all of a sudden, this jumps back to 2005. That's a software problem. Okay, there's something wrong with the software that changed this timing when it shouldn't have. And it's from an arrhythmia logbook. So you don't want that happening in your pacemaker. Now, some of these can be life-threatening. This is from an announcement of a voluntary recall from a Medtronic device. And this is a device that you could use to set the amount of a drug that was administered to you automatically. Okay? And part of what you were doing is setting the period at which you were administered the medication. So they had not labeled the hour and minute field. And because they hadn't labeled the hour and minute field, people were given medication at the wrong period and people died. So
It's interesting to me that was considered a software error instead of a user interface error.
well, so that's another issue. And in general, in security, it's an issue. When you look at the way we fill out trouble reports in software, we rarely have a category that tells us to some level of granularity the nature of the problem, especially when software is a small part of the system. You might just see software error, but you don't see that it was user interface or security or, or something else. So I just read a paper recently where one of the recommendations was to redo the way we do trouble reports so that we get enough information from the trouble reports. Yes?
Why don't they say force certain formal methods testing to go on the software before they release it to prove that it has the properties of, or at least avoids things happening such as this?
So that's a question you could ask more generally, not just about medical devices. There are lots. So I used to be associate editor-in-chief of IEEE software, and every 10 years we would do a list of the top 10 problems in software engineering, and they were almost always the same problems. And most of them were management problems, like enforcing certain activities that should be done before something's released. So I don't think it's a problem specific to medical devices, but I think especially with things like medical devices, you've got competing manufacturers. You know, it's like anything. It's like any other product. You've got competitors. You're trying to get on the market first, and with 510K, if you're showing substantial equivalence, then you may not think about redoing some things that were done before. And remember, I showed you that that a large number of the problems happen after the device is fielded and you've applied updates. Okay? Now, also think a little bit about how some devices are developed. If you talk to medical device manufacturers, yes, some of them have large development groups. They come up with great ideas, and they have what we would all consider a reasonable software engineering process. But also often, you find that at a Christmas party, an engineer who lives down the block from a doctor is talking about a problem the doctor has, and the engineer says, oh, I can build you a device to fix that problem. And before you know it, they get some venture capital, and they create this device. And so in situations like that, you're not likely to have the same kind of software engineering processes imposed that you would find in large organizations. Now, does that mean only large organizations should build our medical devices? Probably not, but it's hard to find the sweet spot. Go ahead.
From a feasibility perspective, though, do you think it's actually more feasible to do this in the same desktop operating systems where you can start managing?
Well, the software in some of these devices is more sophisticated than you think. And I'll show you in a little while some interaction problems where you might, even with formal methods, you might not be able to have anticipated some things. Okay, so I hope by the end of the hour I'll convince you that some of this is a systems problem, not just a software problem. Okay? So let me go on. So here's an adverse event report. We're all taught in our Security 101 classes not to do buffer overflows. July 30th of 2007, all 3 channels of an infusion pump failed due to a buffer overflow in memory. And the blood pressure dropped, and the pump was changed, but not in time, and the person ended up brain dead. So, you know, you could ask yourself, should we just use checklists? Doctors are using checklists now before they do operations, just to make sure, it sounds crazy, that they all washed their hands, that they all, you know, that they all followed exactly the right procedures. These are some simple things we might consider as a community to enforce among ourselves, that we have simple checklists like, did you check for buffer overflows before you released your software? Now here's some guidance from the FDA. And again, you probably can't read this very well, but it's taken right from the FDA document. You can find this online. And it says that there's a need for timely software patches. Well, what does that mean? We all have seen error messages like this. We're in the middle of an update and the update wasn't completed. So if you have a medical device and you're updating the software, we still are not very good at making sure that our updates are done correctly and completely. Here's an example. I wanted to try to get a sense of, you know, how often do some places do updates. Oracle Sun releases over 4,500 patches every year. It's a lot of patches. And if you have software on which you depend, and it's based on an Oracle product, there are a lot of Oracle products. And I'm not picking just on Oracle. You can find data like this for almost every company. That's an awful lot of updates to have to worry about. Now, in addition to that, software is very different from hardware. Remember, we're looking at a process where we have a predicate device, and we want to show equivalence of the new device to the predicate device. And sometimes the predicate device is hardware, and the new device has software in it. So does it make sense to have hardware be a predicate for software? Well, software is significantly different from hardware in several ways. One is developer optimism. We tend, more than most other engineers, to think we're always finding the last defect. And in fact, there were some studies done about 15 years ago at the University of Maryland requirements engineers are not so optimistic. They don't always think they're finding the last defect, but the testers think this is the last defect and then they're done. They're surprised by yet another defect. Now that's from a relatively small sample size, and I don't know that there have been a lot of replications of that study, but still there's some suggestion that we tend to be over-optimistic, and we have a lot of confidence in our testing techniques and our coverage. So for instance, we might demonstrate path coverage in our tests, but there's a lot of evidence in the testing literature in software engineering that that kind of coverage is not enough. There are all kinds of different coverages, and yet this is exactly the kind of evidence that you might submit to a 510K process to show that you've tested enough so that the changes are equivalent, substantially equivalent to the predicate. Another is software is discrete, not continuous. So we have sensitivity to small errors, right? So if I'm building a bridge and something is off by a millimeter or so, it probably doesn't matter for most hardware applications. But an off by one error in software could be catastrophic. We have limited test interpolation. So because, again, I'll use the bridge example. If I test the strength of a bridge at 1,000 pounds and 100,000 pounds, and in both cases the bridge shows no sign of wear, I can assume that between those two numbers the bridge will be fine. But I can't do that at all in software. There's no way to interpolate like that, except perhaps with equivalence cases. And in a case like that, formal methods might be helpful, but it's not a guarantee. And then we have no safety margins in software the way we do in hardware. We can't double the cables on the Brooklyn Bridge the way Roebling did to make sure that it would stand up the way we can't do that in software. So we don't have the same kinds of safety margins. Yes?
I think you can do it in software, we just don't. And in fact, in some places it is, right? So places where they really care, they'll look at the same system independently multiple times, and they'll put majority votes in the outputs of the system.
Yes, although, so what you're talking about is N-version programming, essentially, right? Or N-version programming, N-version design. It comes from... Okay, so a guy named Avitsenis at UCLA years ago wrote a lot of papers on N-version programming, and the idea was that if you have separate teams write the software to the same specification and you have the voting procedure that you talked about, that would guarantee that the software won't fail because you've got all these different designs. So, well, but John Knight and Nancy Levison tested that hypothesis. And what they found was that we tend to teach our students the same kinds of things in the same way, and so they tend to make the same mistakes. So even if you have what seem like totally independent design teams, they still come up with very similar designs with very similar failure modes because of the way they were taught and because of their experiences in the classroom. So yes. So on the other hand, the formal methods people would say that formal methods can help counter that. And Les Hatton and I did an evaluation of a system that was designed using formal methods. And we found that in their, I don't know what the current jargon is for this, but we used to call them case statements. You look at every case, and there's no fall-through case. There was no case that said, well, just in case we didn't get all the right things, here's what you do. And they were so convinced that their formal methods were correct and complete, they said they didn't need that. And now, it was true that that particular system, which was an air traffic control system, hardly ever failed. And when it did fail, there were no catastrophic failures, at least up until the time that we looked at things. And we looked at over 3,000 trouble reports. But by the same token, we thought that it doesn't take that much extra effort to add that extra catch-all statement to make sure, to have a second line of defense. So I think that speaks to the over-optimism that we have in some of our techniques. So I think we need to get over that somehow. But I think we also need to recognize that's something about software that is very different from hardware. Okay? So this Trust in Cyberspace report was written a long time ago. Is Cy still in the room? No, he would remember when it is. I think it was in '92. Trust in Cyberspace, the National Academy of Sciences report. They were talking about networked information systems, but it's true of current information systems and certainly of medical devices. They are large and complex. Most people haven't had a chance to study a lot of them and learn lessons from them. And so we have a poor understanding of design and engineering practices. If you look at a lot of the failure literature, you'll find that the software that's the most solid and reliable is often the software, and I'm talking about large systems, the software that's the most reliable is the software that was developed where there was a person or a small team that had an overview of the whole system and understood how every piece contributed to the whole. Often we don't build systems like that because they're so large and unwieldy, we have to chop them up in pieces. And that's where we find that we get interface errors being the big deal errors. So I recommended to the committee that hardware never be a predicate for software. Okay? Now, you'll see some of this discussion in the committee report, which is also available online, but it's not one of the high-level committee recommendations. Now, here are some of the guidelines from FDA software guidance. And in particular, the FDA suggests that we need to assess the adequacy of off-the-shelf software in order to determine what else we need to do to validate the software for a device manufacturer's intended use. Now think about that. We're building devices now using things like commercial off-the-shelf operating systems or open source software. So how do we evaluate that? Saying that we should evaluate that is one thing. Being able to do that in some reasonable way is hard. And we already talked about the update problem. So what happens when you've got a medical device on which somebody's life depends and it's built on an operating system that has updates that may have nothing to do with the device? Right? So if I have a Windows-based device and Microsoft is updating Windows, Microsoft shouldn't be held responsible for the life or death of somebody who's got a Windows-based medical device. But how do you evaluate that? And how do you evaluate each update? When I was at RAND, they used to evaluate each update and tell us, load this one, not that one. They gave up because it's a configuration management nightmare, and it would be a nightmare like that for a medical device as well. So they require software validation. It's part of their quality system regulation. And they say specifically what I showed you before. They apply to software used as components in medical devices, software that is itself a medical device, and software used in the production of the device or implementation of the device manufacturer's quality system. Okay? Now I'll give you an example that's been in the newspapers recently. You may have read about the metal-on-metal hip implant that's been recalled. It's called the Dupuis hip. The hip used to be made of plastic and metal. It was approved using the 510K process because it's substantially equivalent except that it's metal on metal. So you're already thinking, what does this have to do with software? Well, how did they show a substantial equivalence? They showed it using simulations. And it turns out that the simulations looked almost exclusively at the typical case of how the ball and socket would work together, metal on metal, but not on the extreme cases. Well, who were the customers of this kind of implant? Many of them were athletes who wanted to be doing extraordinary things, bending their legs, for instance, with a hip implant in ways that are not particularly good when it's plastic on metal, but the metal on metal can handle it better. But what was happening was that metal shavings were being created and got into people's bloodstreams, and they now think this may become the most expensive and most widespread recall ever. And so using this sort of guidance, you have to wonder how they evaluated the quality of the simulation, right? They used software to do their simulation, so you'd have to look at whether the software was appropriate, whether the programming of the simulation was appropriate, a whole variety of things. And so software is popping up in places that it never used to pop up before. So
Was that simulation software required to go through FDA clearance?
well, no. Well, I don't think so. I think, but in examining the evidence provided by the medical device manufacturer, it may be the case that somebody at the FDA should be familiar with different simulation packages and their quality. Maybe, I don't know, I'm just speaking off the top of my head, but maybe it was a homegrown simulation package. Maybe it was an off-the-shelf package. Maybe the parameters weren't set correctly. I mean, it could have been a whole host of things. Yes?
I was just going to ask, you know, what did the team look like that was designing this simulation software? Because did it include doctors or orthopedic surgeons or people who knew how, you know, how the body actually moves and, you know, and took into consideration the people who were actually going to want this device, or you have no idea?
I don't know yet. I've been trying to read as much as I can about this implant, but because it's just happening now, there have been, each article in the newspaper gives a little bit more information, but the picture isn't clear to me yet. I don't know that it's clear to the FDA yet, and I don't know how much of what's available as information has been made public yet. As you can imagine, the device manufacturers want to make sure they know what the complete story is before they let a lot of the information out, because especially with software, things that seem to have one cause initially may very well end up having another cause entirely. So here I wanted to highlight computer systems used to create, modify, and maintain electronic records and manage electronic signatures are also subject to validation. So fairly recently, things like this have come out, and they claim that, and they suggest that the FDA is going to regulate health IT. They've already explicitly said electronic health records are considered a medical device, and they will be regulated. And now they're trying to figure out how that regulation will happen. Now, this is all happening in an era where we're cutting back resources of government agencies. So even if you look at the recent cantaloupe, the listeria outbreak, which is also under the FDA, the FDA said that as a result of that outbreak, they were going to, this was just in the New York Times last week, they were going to examine 600 sites. Well, so far they've examined 35 because they just don't have the resources. So I imagine that they have the same problem with medical device regulation. There are things they'd like to be able to do. They know what they would do if they could do it, but they just don't have the people and the resources. Yes?
Is there some clear rule when software hits the threshold for trying health software versus, I mean, I'm just wondering about apps that are on the App Store right now.
There's there's legislation about that right now. It's out for comment, so if you have thoughts about it, you can give your feedback to the FDA, but the proposed rule is if it would influence you to make health decisions. That's the law.
Broadly, but so just
Right.
if
it's not, if it gives you general, so if it just tells you how many calories you're eating, no. But if it tells you based on your body weight and provides you personalized feedback about what you should or shouldn't eat for the rest of the day, then it is. So that's the line that's proposed currently, but again, it's out for comment right now, and they're low resources to actually deal with stuff.
Yeah, and I'll show you some examples in a minute of where it's hard to know what the line is. But the good news is Kevin Fu is on sabbatical this year, and he's an advisor to the FDA. So there is somebody with some software expertise talking with the FDA. And he's not the only one, but Kevin has been particularly active, and so I think that's all good news. Now, this is a requirement from the FDA that says that all new development projects and all changes made to existing medical device software are subject to FDA scrutiny. But what does that mean for updates? If we're getting 4,500 updates just on Oracle software every year, how in the world are we going to evaluate all of them? And from the device manufacturer's point of view, that means these are new devices, some of them, that are not available to people who may really need them. So The FDA states in some of its guidance that it wants objective evidence, and it wants to see that the requirements through software can be consistently fulfilled. Well, these are problems that we've had in software in general for a long time. They're not just FDA problems. So when we figure out how to do some of these things, we need to tell the FDA. So here we are wanting things that are not fragile, and yet the FDA guidance says they want objective evidence, they want predictability, and they want consistency. And it's not really clear how to get from here to there. So we need some sort of systems approach. And here's an example, and this actually comes from one of Kevin Fu's papers, which is available on the I3P website. The vision that a lot of the device manufacturers have related to software and to electronic health records is that you might have some implantable device, okay? And your doctor is sitting at his or her desk with a laptop and is getting feedback from your device. This is all being communicated electronically, right? So you might, for instance, have a pacemaker and your data are being sent to your doctor. And your doctor can see this on her laptop, and she sees that the data suggests that maybe the settings on your pacemaker should be changed. And so using her laptop, she communicates with your device and changes it. And it's all, you know, invisible to you. And the goal is to keep you healthy without being intrusive. Well, imagine if you looked at the vulnerabilities of a system like this. Okay? And imagine if you replace this, which is what's happening, with a series of cloud providers, right? And where are you getting updates? You're getting updates here, you're getting updates here, you might be getting updates here. You've got lots of different players, lots of different software. And if something fails, doing the troubleshooting can be a nightmare. In the meantime, you've got someone who's suffering because the device isn't working. So here's an example also coming from Kevin Fu's research group. They wanted to look at MP3 players. They used iPods interacting with pacemakers and implantable defibrillators. And their initial goal was to see whether if you're listening to your iPod, something on your iPod, does that interfere with your pacemaker or your defibrillator? And they found that actually no, there wasn't any problem between the iPod and the defibrillator. But what they did find was that there was interference from the headphones. That in 14 of the 60 patients, there was demonstrated interference, and it actually affected the pacing in the pacemakers in 4 out of 27 pacemaker patients. And it inhibited the defibrillator detection in 30% of the devices. So they started out looking at one thing, but they found another thing that was a real problem. So you have interference. Now, if I'm a manufacturer of headphones for an iPod, should I be worried about pacemakers? Probably not. But if I make pacemakers, I have to worry about how they might be used and in which contexts, and put warnings on my device, which means I have to anticipate all this stuff. So this is a really hard systems problem. So they concluded that there's clinically significant interference when the headphones are placed close to the pacemakers and the other devices. And they documented what all of these are. And I left on these slides the reference. I have all the references at the end, I think. So they decided that the headphones have to be at least 3 centimeters from the device. Okay, so they can start putting warnings on devices. There are ways to deal with some of these, but you have to recognize the problem first and do the troubleshooting. So we're imagining eventually a system that looks more like this. It's sort of the picture I had before, but exploded to show lots of different devices communicating in lots of different ways for lots of different medical reasons. And you may have some sort of cloud in the middle through which all of this happens. Now, there are other systems issues, like how do we do updates? How do we protect privacy when all of our medical information is floating around in the picture I just showed you? And how do we implement what's called break glass access? Again, we tend to think of the typical case, but not always the extreme case. So we may set our privacy settings so that only certain people can look at data. But in an emergency, we want anybody who can help us to look at those data. So we need to think about these in advance. How do we detect security and privacy breaches? And when we suggest requirements such as reliability requirements, most of those measures of reliability aren't available until the system is already working. So we use surrogate measures, and most of those measures are inadequate. And to give you an example of how difficult it is, for instance, to measure reliability, the IEEE standard for measuring reliability, the committee couldn't come up with any consensus. So there are 22 different ways to measure software reliability. But really the only valid one that actually addresses the definition is one that you can measure only after the software is fielded. And you don't want to wait that long. So we still have, even after all these years of looking at software reliability, we have a lot of work to do to come up with ways to predict reliability that are useful. So what can we learn from the predicates? So we want to be able to ask the device manufacturers to give us some evidence about substantial equivalence. So we want their evidentiary records to be complete and consistent. We want them to tell us about reliability, availability, and maintainability, and sometimes that's hard. And typically, there are no documented arguments to support their claims. Right? They provide data, but they don't always organize the data in ways that are sensible so that we can say, yes, this evidence suggests that this claim is true. Simulations, as I described, they're not often realistic. There are undocumented assumptions. There may be missing variables. We don't usually test completely. We often can't. We often have to field things before the testing is complete. And testing just shows a flaw's presence, not absence. I talked about optimism bias, and there are unanticipated consequences. We also have feature interaction, like the interaction of the headphones with the implantable devices. So we have to figure out how to get some data from our development and testing that can address a lot of these issues and give us more confidence. And then post-market, once something is actually in the marketplace and being used, right now the only thing we have available is recall data. So only when something fails do we start to get data. And maybe we should require data even before something fails, but then we have to figure out, well, what would those data look like? And what's the burden on the person who's using the device and on the manufacturer of the device? We might want to keep records of applied updates. We might have feature interaction again, which means we would need information about the context. And this is only going to get worse as we connect more devices. Yes?
Is there anything like any equivalence process for devices, like equivalent to clinical trials?
No, not usually. And that's because it's for a variety of reasons. One is, you may have come in late, I mentioned at the beginning that unlike drug trials where you can get as many people as you want to be in a trial, for many of these devices, there are only a small number of devices being used. And so it's very hard to do something that's statistically significant. On the other hand, there are domains in which problems like this have already been addressed, like nuclear power plants. In order to open a nuclear power plant, you have to, in the UK and somewhat here, you have to submit what's called a safety case to the Nuclear Regulatory Commission here and to the equivalent in the UK. And it shows all of your evidence and all of your arguments and all of your claims. And there are formal ways, there are languages and tools for organizing all of that evidentiary information. And until that evidence and those arguments are analyzed and agreed with, the nuclear power plant doesn't go online.
If it is a small group of people getting the device, then it's relatively easy to track that.
Yeah.
I see
Yes, but you have so many variables that you can't be sure which variable is causing what you're seeing. Yes?
So what I haven't seen in all this is the balance of risk. That is to say, what is the risk of the patient not getting this device in the first place versus the potential risk of a problem with an uptake? And this seems to be sort of lawyer speak the whole time, which is we need to minimize all risk. There's no such thing as, in the real world, there's no such thing as getting rid of risk. And what we need to look at is balancing risk. And what's the benefit to the patient versus potential downside?
You're absolutely right, but in order to do that risk assessment, you also need the same kind of data that I'm talking about. If you don't know what the risks are to the patient, then you can't balance those risks with the benefits to the patient.
Well, in some cases, you can sort of assume a worst-case risk. So like a hearing aid,
Okay.
assume the worst-case risk is that it deafens the patient. Right? I mean, if it goes on really loud, it gets rid of whatever hearing aid is.
Okay.
So we have the worst-case thing, and now we can look at that compared to what's the possible worst thing that could happen with the hearing aid. So assuming that these attacks don't happen, the patient gets good hearing, and there's some small chance that it's going to attack due to an update. I mean, you can make a reasonable argument. I mean, in cases with an implanted hip, I agree, it's more severe because the worst case is death. But it seems that all of this doesn't take into account the balance of risk that we really like to have in medical scenarios.
Well, I think until we can get more data to understand the implications of what we're doing with the software, we can't address the risk question, and we can't. I'm not saying that we shouldn't be building medical devices with software. I'm saying that we should be thinking about the implications of putting more software in devices and changing the software. Especially, I showed you how much of the failure comes from the updates. So.
I don't disagree. Obviously, we need to look at engineering. I just worried that these regulations and other regulations, you said most of your community was made up of lawyers and regulators.
Well, and healthcare professionals. And healthcare professionals. And in these open public meetings, we had a lot of testimony from people who use devices, have implantable devices. I mean, we tried to cover the spectrum, and we invited all the constituencies, including the device manufacturers, to come and make presentations. So, yes?
I was just going to say that hearing aid in an extreme scenario could have an interaction with a pacemaker that the same patient has. And that may actually lead to death. So I think in the worst case for almost all medical devices, one of the
My electric oven would have an interaction with the pacemaker. I mean, I have an induction oven that works completely based on magnetics, which is exactly the problem we're having here with earphones. We can't anticipate every possible, interaction there is in the world. It's just not a reasonable suggestion.
Well, but I think my point is we could try to anticipate more of the interactions than we do. I think we tend to think of our systems in isolation when we need to think of them as interacting. But let me get on to the committee recommendations. So let's go back to the 510K process. So there have been problems with existing predicates. Remember, I said you have to show substantial equivalence to a predicate device. So the prior clearances are binding predicates as predicates. So once you get clearance, once you are told your new device is substantially equivalent to an old device, that's binding forever, even if recall data show that there's something wrong with your device. So there's no assurance of predicate safety or effectiveness in the decision of substantial equivalence. Nobody goes back and looks at the predicate device and says, is this still safe and effective? All they look at is whether the new one is equivalent to the old one. And there's no assurance that prior clearances were correct. And so there's no practical way to remove what we would all consider undesirable predicates. Now, this is compounded by the fact that, I think I have this on the next slide. I don't. There have been, since 1976, there have been various ways to use this notion of substantial equivalence. So you can imagine, for instance, I might create a device that has several different features. I take one feature from one predicate device, another feature from another predicate device. These are called compound predicates. And so you end up with a device that is really very different from each of the individual devices from which it's taken features. But each feature is substantially equivalent to the one before. So it gets really hard. Everything gets tangled together. It gets really hard to have traceability back to the original device that got approval, not 510K clearance. So the fact that a lot of these things are binding makes it really hard to untangle everything if you find a problem. Now, the FDA estimated that 40% of the devices cleared through 510K, that's about 120,000 in the last 35 years, are no longer on the market. Now, there could be lots of reasons for that. It could be that they're obsolete. Nobody uses that device anymore because they don't need it. It could be that the sales were poor, so it was taken off the market. Or it could be that it was unsafe or ineffective and it was taken off the market. But there are no records to help us differentiate among the 120,000. All we know is that they're off the market. And yet, all of these things are binding predicates in the current system. And the FDA doesn't track predicates, and they don't have IT systems to collect the information that would help them track it. Okay? So what the committee decided is that the 510K clearance process is not intended to evaluate safety and effectiveness. It's focused almost entirely on substantial equivalence. And so it can't be transformed into a pre-market evaluation of safety and effectiveness as long as substantial equivalence is the central part of 510K. So what the committee recommended instead was coming up with a new process for doing this sort of evaluation. So we recommended a medical device regulatory framework with integrated pre-market and post-market regulation throughout the device life cycle. Now, this is what we would do, we would all do for software, right? We always talk about the software life cycle. We look at what happened before the software is fielded, and we also keep looking after the software is fielded and changed so that we can continually learn lessons, or at least that's the ideal. That's exactly the sort of thing that we recommended to the FDA. That rather than try to patch the 510K process, just focus on the goal of safety and effectiveness instead of on substantial equivalence and come up with a more comprehensive life cycle-based regulatory framework. Yes?
Does this also take into account the implementation portion? Because, for example, I've heard a number of first-hand accounts of pen testers who, on a job at a medical facility, suddenly find they have shells on some of the rather serious medical devices that are currently somehow on the network. So the devices may perform adequately.
Mm-hmm.
They meet their test, they perform what they were meant to do, but then when they're in the hospital, their internet-connected devices potentially are on the hospital's network. Suddenly now, someone can get remote access to them. But when they were tested, say, in the lab, they performed everything else okay. So I guess implementation vulnerabilities or something like that might be.
Yeah, I think that's more than implementation vulnerabilities. I think it has to do with context of use. That the testing happened in one context of use, but the day-to-day use of the device is a completely different context of use. And so I think that has more to do with the changing context than with the testing itself. Yeah, sorry. So, yeah, I think, yeah, so this is my conclusion. So we need to understand the roles of software in medical devices. We don't really, as much as we should. And the FDA needs to analyze software's potential effects on the safety and effectiveness of devices. And I don't mean for you to take away the notion that we shouldn't be putting software in devices. We can do things to save people's lives and change for the better, their quality of life with software in ways we never could with hardware. But we need to look at all the potential risks. And we need to focus on evidence-based procedures that ensure device safety and effectiveness. And at the same time, I think the FDA needs to review and update its guidance on software validation. They tend to rely on best practice. And best practice often just means what everybody's doing, but not necessarily really best. It goes back to the evidence-based procedures. We need to be able to demonstrate that the practices we're using really have a positive effect on the software's quality.